Good morning, everyone. My name is Dario. So how this is going to work is we're going to swap with Andres to present cases. And without further ado, I'm going to go ahead and present the first case. We don't have any disclosures. So case one is a 53-year-old male, no significant past medical history, hyperlipidemia, and came in for consult because a systolic murmur was auscultated in a PCP visit. In terms of symptoms, he just complained of palpitations. He denied any major cardiovascular symptoms. And in terms of functional capacity, he exercises 5 times a week. He does weightlifting, aerobics, reporting no limitations whatsoever and no significant symptoms during exertion. So pretty good functional capacity. This is his physical examination and his initial encounter. Basically, pertinence is he had a 3 to 4 diastolic decrescendo murmur. And that was it. He didn't have signs of any heart failure symptoms or signs in the initial encounter. So I'm going to pass it to Andres to go over the initial echo.
Okay, so this was a transthoracic echo done before seeing us in clinic. In the top left is the parasternal long axis, and zoomed in immediately to the right with color, we start to see a significant, possibly significant regurgitant jet. The color gain on this is turned up by the sonographer, so there is a lot going on. Maybe done because it was underwhelming with a normal color gain. But then going to the short axis to the right in the top right corner, we start to see what appears to be a bicuspid valve, Sievers type 1 with fusion of the right and left coronary cusp. And again, with color immediately below in the bottom right, we see where the regurgitant lesion or regurgitant jet is coming from, but we don't quite have an overall sense of how significant this jet is. We think it might be significant. We have a dilated left ventricle with normal systolic function. We have a widened pulse pressure, a pulse pressure of near 90. And then looking at the M mode in the bottom left and in the middle, we see eccentric closure lines of our aortic valve. On the left and in the middle bottom, we see normal mitral valve closure. You can argue maybe it's a little early, but it's right before that QRS complex. Okay, then apical 4 and apical 5, more or less, showing again we have a dilated left ventricle, dilated left atria and right atria. RV function is normal. Systolic function of the LV is normal as well. And we start to see again this eccentric regurgitant jet, which might be significant, but we really can't say based off of appearance. Doing some quantitative measures comparing the stroke volume from the left side and the right side, we do calculate there to be a regurgitant volume of 70 milliliters. Our stroke volume is also elevated from the LV. Our stroke volume of 131, and this gentleman's BSA was about 1.8, so our stroke volume index is close to 50. Again, looking at the top right is our PW at the LVOT, again showing that it's placed in the right location in the LVOT. We have a high VTI and a high stroke volume. Right below, we don't have any significant stenosis. Our peak aortic valve velocity is under 2. And again, during diastole, we see regurgitation, but we can't quite capture the jet, probably because it's an eccentric jet.
Andres, can I comment a little bit?
Yep.
So one thing that's interesting is when he was first seen by his primary physician, they heard a systolic murmur.
Yes.
Which they may have been right. It was probably the high flow state. But if you look at the first slide that you have, the first set of echo images, I know the topic is chronic AR, but from those, you can kind of discern that this is hemodynamically significant AR. So looking at the top left, just using the scale that you have for the 2D echo, you can tell that the LV is dilated. Mm-hmm. And it has this kind of globular shape that looks like a football. And then in the middle, here the issue is, and this is kind of a pet peeve of mine, the color box is so big that the frame rate of the color is just so bad. And you get this kind of very, very short flash, and if you're going through the echo quickly, you'll just miss it. But you see actually a very nice, sizable flow convergence without even shifting the color baseline. So it kind of tells you that, hey, there's something here. I'm not so sure this is bicuspid also. I mean, if you look at the short axis, it has this kind of double contour, which I think he has a leaflet prolapse. You kind of see, which you also see on the parasternal long, of that kind of anterior or right-sided leaflet. But we'll see if I'm right or wrong. This is that, when the color, where the sector of the echo kind of cuts through the leaflet in two sections, it kind of shows you two edges to the leaflet. And this is kind of a feature of prolapse. Just a little bit
He's
further.
51, so the odds
Yes.
aren't in your favor.
That's true. That's true. Yeah. He's a kind of a prototypical young AR patient. Yeah.
Yep, I agree. Oh, Dr. Faza, did you want to say something?
Another aspect of this echo that's important is when you have an eccentric jet. I like that how you quantified it. It's hard to use continuous wave Doppler. If you have a good vena contractor, you want to use that. But a lot of the measures we use can be falsely misleading in this case because it's an eccentric jet. So you want to look at other markers like LV enlargement. You want to look at a vena contractor if you have it, and always try to quantify when you have a good RVOT diameter and RVOT TVI. Use those to derive your regurgitant volume, because just relying on color in these eccentric jets can be very deceiving.
Yeah.
So let me be grouchy as usual. He's got aortic regurg, his ventricles enlarged and globular. He's got a systolic murmur, which tells you that the flow is high, so the regurgitant volume is high. Why do you even want to calculate his regurgitant volume? I mean, what's the mystery here?
I think a comprehensive echo is still key.
I know
we're
we do
looking
that,
at some cases are in between. This one may be a little bit more clear cut, but I think the quantitation has value also in his long-term course. So we looked at recently, the reverse remodeling after surgery and how that relates to the severity of disease prior to the operation. There's a very nice correlation between the extent of regurgitation and reverse remodeling. And I think long-term for these patients, a key question will become is, how can you sort of normalize their trajectory? Can you normalize their left ventricle size in their next 30 years? The regurg volume, I think, may have value here, or the precise severity summation.
I mean, one other point I'll make, from a lab standpoint, you don't want to quantify just in the cases where you absolutely need to quantify, because you want to get a pattern, approach of how you do it, and so it's important to do it in the spectrum of cases. It's kind of like you don't learn how to do PCI just by the cardiogenic shock patient. You want to do some of the elective cases as well. So you have to have kind of an approach where you do it systematically, not just in the cases where you say, I absolutely need to do quantitation here.
Well, I'm not just asking. I mean, I understand why you want to do it academically. And look, I'd be disappointed if you didn't. But from the point of view of the clinician taking care of this guy, likely you're going to replace that valve. Likely you're going to do another echo. If the ventricle is still dilated, you're going to start him on medical therapy for a dilated ventricle.
Yeah.
We probably don't need to discuss right now what that is.
Yes.
So I'm talking to this guy in clinic, and the regurgitant volume is not going to be part of the discussion.
That's true, yeah. I think managing...
Unless he's a cardiologist.
In
You
this case,
said
I think
replace. I think there's some other options out there too. We can talk about that.
Replaced or repaired, something.
I think the color is impressive in this case, but a lot of times in these eccentric jets, the color might be less impressive. And you also see older patients with non-ischemic cardiomyopathy having degenerative changes in the aortic valve, now developing AI. And then the quantitation becomes more significant in these cases. Maybe not so much this patient, but in other less clear cases.
All right, good points, exactly. This is single valve disease, we kind of know what's going on, but if we have multi-valve disease, coronary disease, prior heart failure, having the volume, points us in more of a clear direction. And yeah, this jet is underwhelming, it's slightly eccentric, but in other cases, it'll be even more underwhelming and we might miss it completely. Okay, so here are other clues to significance of this aortic valve regurgitation, and maybe in other people it would be more clear cut. In the top left is PW through the abdominal descending aorta. There's a smidge of reversal there, but it's not the holodiastolic reversal that's clear and we can take to the bank. And in the bottom left is CW through the descending aorta, but in the thorax, and there is diastolic reversal, but that can happen with someone with an elevated LV-ADP or bad diastolic dysfunction. Here's the LV global longitudinal strain. Looks like it was, the tracings to me show that it was tracking well. We had good images. And the GLS is 18. If we say 17 is reduced, we are above the normal. But with someone with significant AI, more than 19 is kind of the bucket where we don't have to worry, or there's been studies showing that there's no change over time. But the 15 to 19 bucket also is starting to show that there is it's a sign that the ventricle is not happy and maybe earlier intervention is required. And then below 15 it's definitely reduced. This ventricle is not happy. Okay, next test for the panel. Or anything that we want to add on, or I think it's kind of clear now. Surgical referral and look at the roots, but anything
in a
else?
young person with a possible bicuspid valve, I'd want to get some type of imaging of the aorta. Up to 40% of patients with a bicuspid valve can have bicuspid aortopathy, so I'd want to know what his aorta is.
Good, okay. So next
So
test.
the other thing I would do in this guy is, your first slide said he's a weightlifter. If this guy has aortopathy or if he's got a bicuspid valve, first thing you've got to do is got to counsel him about weightlifting. If, he's, doing curls for the girls, that's one thing. But if he's, doing some of the canonical stuff with heavy weights, deadlifting, et cetera, you got to tell him, look, you're at risk of getting to the OR a lot faster than we would otherwise, because you worry about him valve salvating and dissecting.
This is a side note, but are you guys counseling patients about the use of fluoroquinolones?
Yeah, for aneurysms.
And aortopathy and
very important for
aneurysms, yeah.
aneurysms. Yeah.
We should.
Yeah. I think
So
it's,
generally contraindicated. There's a black label warning from the FDA several years back about patients have either aortic dissection or an aneurysm that increases the risk of growth and dissection. So I put it as an allergy on all my patients that I see for aneurysm.
very important.
Excellent. All right, so we went ahead and did a CMR for volume quantification. In here, I have a series of stacks of short axes going from the base to the apex. In the volumetric assessment, we can see that the LV end diastolic volume is 281 and RV is 200. When we index these values to his VSA, it ended up being a moderate dilation of the LV and then mild dilation of the RV. When we compute the stroke volume, subtracting the end systolic volume, we get a stroke volume of 163 of the LV with an EF of 58%, and then in the RV of 53%. So we have a series of 3-chamber, 4-chamber, 2-chamber, and then an LVOT view. And I just want to call your attention to the 3-chamber view on the top left corner. And we can see that there is, again, the extremely eccentric aortic regurgitation jet. It's posteriorly directed, impinging the anterior mitral valve leaflet. And we can see some of the flow also in the 4-chamber. And then I have a series of short axis views of the aortic valve. And if I stop it at the right moment, we can see that this is it has a mini raphe, so it's a bicuspid aortic valve with partial fusion of the left and right coronary cusps. And we did also an MRA, and the patient had a dilated aortic root. Not too dilated, it was mildly dilated at 4.2 centimeters.
And the rest of the aorta?
The rest of the aorta was normal.
Yeah, because for these cases, the key is the ascending aorta to see if that's dilated as well.
Yeah. So the remainder of the aortic dimensions was normal.
This is kind of the imaging equivalent of your Austin Flint murmur, where you see that aortic regurgitation jet is hitting that anterior mitral leaflet.
And interestingly, it doesn't have a lot of sort of effacement of the STJ. It looks like it's just an isolated mild root enlargement.
And how tall is he?
65 inches. BSA is 187.
And from a surgical perspective, this was not my patient, but this would be a hard one to repair. Tri-leaflet AI without an aneurysm, without effacement of the STJ or the root, and an eccentric jet are kind of the hardest ones to repair.
So,
How about Ross?
So he's 5'7". He's got a 4.2 centimeter aorta. You're going to replace that, or are you going to say we'll take care of it later?
Yeah, I mean, so the guidelines say 4.5. I don't know.
So Marvin, what are
Think
the
about that
things
one.
you look at when you think of, maybe a Ross procedure in somebody like this?
Yeah, so, when I am thinking about a possible valve repair, I'm kind of looking at two different things. Is it an aortic problem? Is it a leaflet problem? The easier ones to fix are the aortic problems. So if it's the easiest is the effacement of the STJ, you've got an ascending aneurysm, but the root's normal. All you really need to do is just downsize with a graft your ascending aorta. You're going to bring the commissures closer together. You're going to have good coaptation. If it's a root problem and you have a dilated root, and that's why the leaflets are getting pulled apart, you can do typically a valve sparing reimplantation procedure. You could do a remodeling. Some people still do that. But that gets rid of the aneurysm portion of things and brings everything together. If it's a leaflet problem, once you start having to do something with the leaflets, whether it's releasing a raphe, bringing parts of the leaflets together, it gets harder and harder. If you're augmenting leaflets, patching holes, debriding calcium, all those kind of things, the results kind of fall off in terms of durability. So really, I think it depends upon how young the patient is, how aggressive you want to be about trying to save their valve. If you replace somebody's valve with a tissue valve or a mechanical valve, their thromboembolic risk, bleeding risk on anticoagulation, or endocarditis risk is probably 1 to 2% per year in their lifetime, versus if you do a valve repair and keep them with their own native hardware, it's less than 0.5% per year. And then Ross is the other thing. So as long as their pulmonary root is reasonable size, either for both AI or AS, you can bring that over and is another option for patients.
Thank you. So in the assessment of the severity of AR, in CMR we use phase contrast, which is a technique where we can encode for velocity, using the gradients of MRI. And then in here we see both, a curve where, the curve or the volume above the baseline represents the forward flow, and then we have the volume below the baseline represents the reverse volume. So in the reverse volume, we have, regurgitation of 51 ml, and then the forward volume, around 155 ml. So, we have 51 ml, of aortic regurgitation, and if we do the math, doing the ratio, we get a fraction of about 34%. So this is one of the ways that we can assess for the severity of regurgitation in MRI, using a direct method. Then in here, this is a high resolution view of the aortic valve at the level of the annular plane. And basically, when we stop, this cine image in diastole, we can actually measure the anatomical regurgitant orifice. In this case, was 0.32 centimeters square. And then just as a, confirmatory kind of test, to make sure that we're dealing with a severe case of AR, we can also do phase contrast in the descending aorta, in this case, the thoracic descending aorta. And in the, volumetric representation here, we can see that there is holodiastolic flow reversal, and that kind of cements that we are dealing with a severe case of AR. So a surgical consultation was, performed, and we have this patient's STS score. I'm gonna, ask back to the panel if you have any further comments based on the data that we have so far and further recommendations.
Did he have any scar? Any LV scar by MRI?
No scar.
So, I mean, clearly this is a low surgical risk patient, young patient, so this is going to be some form of surgery, right? This is going to be a repair or replacement or Ross. Transcatheter is, for high-risk patients. We have a randomized trial called the ARTIST trial, which is looking at randomizing patients who are not high surgical risk, but this patient, in his early 50s would probably not be most suitable or appropriate for randomization in the ARTIST trial. So I think this is going to be surgical.
I think folks in the ARTIST trial, we're really looking for low and intermediate risk, probably folks in their 70s, you would say.
Right.
Yeah, Kershaw?
Yeah, so thank you, everybody. Just to kind of take a step back before we start getting a little bit more into what the therapies may look like. If I recall, it was a young gentleman, lifts weights, pretty functional, with a murmur, who kind of walked into perhaps somebody like my clinic, and then we kind of did our assessment. So I just want to, before we kind of start talking about how we decide on interventions, my first questions would be, the gentleman came in with a pretty wide pulse pressure with hypertension. How do you guys think about management of hypertension in an asymptomatic individual like this? We heard a little bit about other counseling things, about weightlifting and antibiotics, but this is a hypertension that we're seeing right in front of us. And then how soon should we be talking to you guys about referral to the valve clinic, about intervention consideration? And then is this a slam dunk intervention? And if so, how soon should we be thinking?
Great questions, Kershaw. I agree. I think what you're asking is the indications for intervention in asymptomatic severe aortic regurgitation is the main question. And when you look at the echo guidelines, I think there is growing concordance among surgeons, imagers, and interventionalists that the echo guidelines are a little bit more conservative. And I mean, I'll obviously let Dr. Shah and Dr. Malafji talk about the incredible work that they have done, which are reshaping the valve guidelines in terms of redefining the volume thresholds and both from ventricular volume thresholds from a left ventricular systolic and diastolic thresholds, which they have found in the work here at Houston Methodist, and that has been duplicated or replicated by other centers from the UK and Minneapolis and other places. So the guidelines are likely to change. Maybe Dr. Malafji, you want to share some of the key findings from your work here at Methodist?
Yeah, I think I agree. I mean, here there's no emergency. This is a patient that shouldn't, go to the OR the next day. But I think it is good for them to meet with the surgeon. When it comes to, how to approach them, they're asymptomatic, like you said. They now fall into the category: do they have asymptomatic low LV function? Currently they don't, but they're kind of close to it because their EF is 56%. Currently we use 55%. So if they're kind of get re-imaged and now their EF is 53%, they're still asymptomatic. Now it's in a time for intervention. If they still don't have that, the current recommendation is to go by the end-systolic diameter or the end-systolic volume. Most recently from the ESC guidelines, they recommend the 45 cc's per meter squared for the end-systolic volume, because that kind of tells you that now they have a decline in their LV systolic performance that's incorporating the LV load. So he's there. He is at the point where he's kind of a class 2B for indication, recognizing that this is a shared decision-making type of discussion. If you're able to get him a valve repair, if you're able to get him into a valve center of excellence, it is reasonable to go ahead. But I don't think that this is a patient that, is immediately operable. But I would certainly get him to meet the surgeon at least. And then we have had that discussion. When it comes to the hypertension, I think very important, we have to try to get at least to below a systolic of 140. This was tested in a randomized trial previously because there was a lot of emphasis on controlling hypertension in AR. It didn't appear to lower the rate of progression by controlling the hypertension, but still the recommendation is you can't have them walk around with a systolic of 150. Choice of medications based on just observational data, ACE and ARBs, perhaps ARNIs, seem to be better. I think certainly you would want to avoid beta blockers if you can. in terms of prognosis.
Well, I mean, way back, was there not a trial of nifedipine that reduced the regurgitant volume?
Yes, yes. Yeah. That was the, yeah.
But, you know, on the other hand, I would look at this as a case of secondary hypertension.
Right.
So when a patient with secondary hypertension, you treat the primary cause.
Good night.
Arvind, you have a
Dr.
question?
Vinay?
And one other question, when we're seeing them in the clinic and it's unclear if on the MRI, I think we're saying this was a bicuspid aortic valve. How do we think about counseling? Is that something you bring up initially when you first talk to the patient about what that implies for potentially other first-degree relatives? How do you guys handle that? Is that something later on? Because obviously this is a lot for this healthy gentleman who just is asymptomatic coming into the clinic.
Yeah, so I'll address it. I mean, if you look at the guidelines, they're pretty clear on if you have a bicuspid valve and you have aortopathy, so you have a dilated aorta, then there's a increased risk in first-degree relatives, and first-degree relatives should really get screened. Now, when they do that, obviously, doesn't mean they need to do that immediately on that same day, but that's one of the things I think is important from a counseling standpoint. The other piece I think also sometimes people forget is if in that first round of screening of first-degree relatives, if there's identified an aneurysm in any of the family members, then you actually need to go to a second round of second-degree relatives as well, because again, there's a genetic association here.
No, thanks, guys. It's great discussion. To add on to Kershaw's question on the asymptomatic aspect of it, all the multi-modality imaging, each one of you got your wish, MRIs, echoes, and stuff. And you know where I'm heading to this. Would you ever use a hemodynamic assessment in these patients to justify the need in the context of doing a right heart cath? Because if you do a right heart cath and the wedge is normal, would you consider that it is still not hemodynamically significant, or is the risk prognostication of the volumes independent of hemodynamics? Because there are times where in these AI patients that I've had, we've done a right heart cath for any other reason and the wedge is stone cold normal, it's tough to imagine that AI volumes and everything is significant, even though it's a snapshot, right? Both are snapshots that we're getting. Would you ever use a right heart cath to figure out the timing? Say this guy says, I don't want to go through the surgery, I want to wait. Do we have enough to say, no, you're going to die, you need the surgery, or would you use other assessments like a right heart cath?
I think a resting right heart cath may not be, sufficient, because, we've seen these, the reason the ventricle dilates, as you know, is, this is the compensation for the volume overload. And oftentimes, these patients will have a normal resting wedge pressure. So if you're going to do a right heart cath, I would favor doing an exercise right heart cath to really see what happens, in the physiologic state. Because, most often these patients, may not have any symptoms, or, they may be asymptomatic. So the main question is the LVEDP, is the wedge pressure going up with exercise? So that's what I would consider if I were to do a hemodynamic study.
All right, great points, everyone. And just to add, also, there was a CCTA done. Coronaries were normal. The CT also confirmed that it was a bicuspid Sievers type 1. The valve calcium score was 1, and coronary score was 0. All right, so we went forth with SAVR, given that the LV was dilated, the GLS was lower than 19, but mainly the LV being dilated, the LV and systolic volume being in the 50s. So this is the intra-op TE. This confirms, if we needed to confirm it again, that he did have this small fusion of the left and right coronary cusp. There was also prolapse of the right coronary cusp. And this is most common when there is prolapse, causing this eccentric severe jets. We have diastolic reversal in the aorta, and our anesthesiologist did a nice 3D showing that this probably vena contracta area is, I don't have the VCA, but all points to this being a significant AI. So attempted AV repair was performed. They attempted RCC and right and left coronary cusp plication, but the valve was deemed not competent, and then they went ahead and did mechanical AVR. And actually, before the surgery, this was discussed with the patients, and they decided that if he can't do an AV repair, go ahead and give him a mechanical valve.
So the one thing I would mention about the Onyx mechanical valve as opposed to the other mechanical valves that are out there, so that's the only one that has a randomized trial that shows that the first 3 months you need to keep their INR between 2 and 3, but after that third month you can drop their anticoagulation down and keep them between 1.5 and 2.
So that's an interesting comment, and this is similar to a debate we have all the time about coronary stents and dual antiplatelet therapy. Is it just that the manufacturer of that valve did the trial, or is this, do you think this is something truly unique to the valve?
Something unique to the valve. So if you look at electron microscopy of the leaflets of that Onyx valve, it's this highly polished thing as opposed to the other valves that are out there. So it's thought to be less thrombogenic.
So Marvin, let me ask you a question. I mean, this case, you kind of cautioned us up front that the likelihood of repair is pretty low. How good do you think the surgeons are at being able to tell, to stratify this patient, I think I can repair this valve, this one I can't? Because obviously I'm sure you go in and try to repair every case, but how good are you a priori at being able to tell? Because that may affect the decision making to some extent. Or if it's a patient you can say, this person's definitely going to get repair, you might think about doing it earlier versus if you say they're going to get a mechanical.
Yeah, I mean, many times we get in there and we're planning on doing a valve sparing operation, valve repair operation, and we find these huge fenestrations that you never saw in the echo. Unfortunately, it's one of those things that you can only many times figure out intraoperatively, looking at the leaflets, looking at their pliability, looking at calcium, seeing if there's these huge fenestrations, usually typically up at the commissures, and that's why a leaflet's prolapsing. So whenever it's an eccentric jet like that, so if it's a straight, central jet, that's usually an aortic problem, STJ or root, pulling things apart. You bring it back together, that's easy to fix. You don't have to do any leaflet work. But when it's an eccentric jet like this, something's prolapsing compared to the others. A bicuspid valve is easier because you have a reference leaflet and you have the prolapsing leaflet, and all you really need to do is kind of make them up to equalize free margin length, typically in height. But once you start to get to a tri-leaflet valve, eccentric AI, it's tough.
Sounds like a great AI project to try to predict.
Yeah.
And
Dr. Faza, you're young enough to lead it.
How would you manage, how would you monitor his aorta post-op? I think they didn't.
Did not. They did the valve. They didn't replace
just the valve. The root was
What would be
4.2.
your strategy for the aortic root in this case?
Yeah, root. I mean, I would. He's going to have an echo follow-up yearly. I mean, I would just follow the root. You can see very well. The upper third of the ascending aorta, you can see well with transthoracic echo. Beyond that, it gets very hard. You're going to want some type of imaging. In younger folks, we're moving towards MRI in these patients just to avoid the radiation. You don't typically need contrast just to get an aortic size on many of these patients.
Okay. There's a few images that Dr. Atkins provided for us to show what would be a good valve repair and not valve repair.
Yeah, so this is somebody I did that had, tri-leaflet valve, very easy to kind of put everything back together as a valve sparing. That was one that worked. Next picture. This is one I did a couple weeks ago. So this is a bicuspid valve. You can see very thickened leaflets, so totally different than the previous picture that you saw there before. I tried to loosen up some of the calcium, tried to play with that fused leaflet there. That person got a mechanical bent on. Here's a unicuspid valve. Another one where they've got the fused raphe that you can see there at 3 o'clock, and then also at 12 o'clock, 11 o'clock there, you've got kind of this horseshoe shaped. I actually split that raphe there of that commissure, played around. There was a bunch of calcium underneath that, tried to make it look like it was going to be something that would work, and that patient also, who's a 32-year-old firefighter, ended up getting a mechanical bent all as well. Both of those patients, Plan A, when I met with them in clinic, Plan A was a repair, Plan B was a Ross, Plan C was a mechanical valve. One of them we got in there, opened up the pulmonary root, and one of the leaflets was prolapsing on the pulmonary valve, so we couldn't use that for a Ross. The other one, his pulmonary root was very small.
So, firefighter, did you say?
Yeah, he actually just does administrative stuff, so we had talked about that beforehand. So yeah, that would be something that I would be very worried about. Not infrequently, I had this conversation last night with a patient on the phone 53 bicuspid valve. Her mean gradient's 57. She's totally asymptomatic. And she absolutely does not want a mechanical valve, and she has a very small pulmonary root.
Marvin, you
She
want
was
to be,
trying to talk me into a tissue valve.
you got to be careful when you say just administrative work.
Okay, so
All
this is the follow-up TT post 1 month post-op, and we can see that the ventricle looks less dilated. Our end diastolic volume is near normal. End systolic volume index is 36 from 50s, and our gradients across the valve look good, and we have a normal washing jet regurgitation lesion. So overall, I would say a good case.
All right, that's a great case. Thank you,
Great
guys.
case.
Thank you.
I think,
Okay, so the next case, we're going to go above the speed limit and try and go quick, okay? All right, so this was a patient seen in clinic, had a recent hospitalization for new heart failure, and the troponin was elevated. So 77-year-old, persistent AFib, COPD, former smoker, some chronic kidney disease. He basically had progressive dyspnea in the months leading to the hospitalization. Was found, again, we'll go through the workup, but was given diuresis, improved with symptoms. Then in the interim of the discharge and seeing us in clinic, recurrent pleural effusion, and it's not malignant, so it's not a good sign. Some atypical non-exertional chest discomfort on review of symptoms. On physical exam, nothing much. There's irregular heart rates. There's apical holosystolic murmur and diastolic murmur. There's murmurs, and given the valve conference that we're talking about, we can expect to see a few. Blood pressure 140s over 70s. Okay, so this is what they did at the outside hospital. We'll look at a couple of the images. Non-dynamic troponin elevation with the old troponin I, 0.3. AFib on EKG, rate controlled, no ischemic changes there. And their echo, which we'll go through, showed a normal LV size and function and a moderate to severe regurgitant lesion. They did a SPECT, they did a cardiac cath, normal coronaries, elevated mean gradients. And he was, the plan was there's significant, maybe significant MR, let's refer him to the valve clinic to see what's next. Okay, so here's his coronaries, normal left and right coronary artery. They, trying to get an LV EDP, also did a ventriculogram, and we don't see these often, but they said there was moderate to severe MR on here, which we do see. We do see the regurgitant flow going from the ventricle to the atria, but there's also quite a significant amount of regurgitant flow coming back into the ventricle from the aorta. So that's the first clue. All right, so here's the echo. Overall, good quality echo. We see a dilated left ventricle, dilated right ventricle, a widened pulse pressure. There's some AI there. It looks mild to moderate at first glance. There's definitely some MR there that's eccentric, wrapping around the atria. Appears going to be significant based on a few things, having a dilated ventricle, dilated atria, high E velocities as well. We don't quite understand the mechanism yet, though, of these regurgitant jets based off of just the transthoracic. Okay, the apical views, again, we see a regurgitant aortic jets that, might be underwhelming, looks mild, maybe moderate. And there will be some clues as to maybe this being more significant. Again, the pulse pressure. This is a 70-year-old gentleman, so the pulse pressure as we age does get higher, but this is getting close to 100.
And it looks like there is a little bit of prolapse of that anterior leaflet. I was wondering if it is all functional MR from the AR and LV dilation, or is there a primary component? But I suspect there is a little prolapse.
Yeah.
Is there some diastolic MR in there too?
There isn't
Thought I was
diastolic
seeing a
MR,
few
but
flashes.
going real quick to Dr. Goel's point, yes, we can maybe say there's some prolapse here of the anterior leaflet, but again, it's not quite definitive.
It's maybe one of those pseudo-prolapse because of just the big annulus. But notice one quick comment on the left side. Notice how that PISA or ERO on the aortic valve, notice how much it varies. In the first beat, it's very impressive, and it's tiny. And this is kind of one of the challenges with these cases. This is a heart failure patient with high filling pressures. If you're going to try to, measure this, there's going to be a lot of variation in the measurement throughout diastole. And quantifying this by echo using PISA maybe not the right way to go, but you have to put everything together with the rest of the volumes. So quantitation here is going to be the tough one, but important as opposed to the other one.
And then I do want to point out that the stroke volume is high, and, or not high, but normal, higher than expected for someone that might have significant MR. All right, M mode, they're in AFib, so this little pause causes fluttering. I wouldn't quite say it's fluttering of the anterior mitral leaflet. Normal closure right before the QRS. Here's our CWs at the aorta, no definitive holosystolic reversal. There's partial reversal in both the abdomen and the thorax. Okay, and so today's clinic TT done here. I would say that their image quality was slightly better, but I think our interpretation of the echo is going to change things. Again, wide pulse pressure, dilated ventricle, eccentric jet for the mitral valve. And also, they're not quite eccentric jet for this aortic valve, but again, somewhat underwhelming maybe. Here's our short axis views, again, showing the jet tricuspid valve and trying to determine the mechanism. Not quite sure about the aortic valve yet, and for the mitral valve, we kind of have a hint that it's primary, but again, need more imaging to say for sure.
Yeah, it does look like there's a little focal prolapse. Yeah.
Okay, so apical views, same thing, different flavor. But so doing some quantitation of the mitral valve to prove that it is, I mean, we have an idea that it's significant, but looking at volumetric measurements, taking the LV stroke volume by biplane and subtracting that from the mitral valve stroke volume at the annulus does give us a MR volume of 66 with a MR fraction of 46%. Okay. Quickly looking at the guidelines, some of the specific measurements for severe MR. If we see a flail leaflet, probably severe. The vena contracta is greater than 0.7. For our eccentric jets, we can't do the PISA radius, and we don't always see the jet. So the next thing is to know that we need to do more testing. And this was the report, which differed from the outpatient one slightly, saying, this is significant MR, we need a TEE, or some other modality to say what is the mechanism and to confirm how significant it is. But, looking at both the outpatient, inpatient and outpatient TTE, the AI was reported as mild to moderate.
So I think these guidelines are good for isolated severe valve disease, but when you have mixed valve lesions like AR and MR, that's the challenge.
Yeah.
It's a challenge, but also the assessment should include ventricular volumes. There should be an attempt at quantifying the AR as well. We don't see the ventricle well, we get ultrasound enhancing agents. So there are many steps that should be performed from that transthoracic before resorting to I'm going to do another test.
Yeah. So here you can still use the RVOT comparison.
You can
RVOT.
use, yes, the RVOT, and you can also use mitral inflow. The difference between between 2D stroke volume and the mitral inflow is the aortic regurg volume.
Yeah.
And of course, if you have the RVOT flow and you have the LVOT flow, the difference between them is the AR volume. And both methods can be used to check on the AR severity by echo. The patient has a pulse pressure of 91 millimeters mercury. This is a big concern. Yeah.
I can't rely on the pressure half-time, especially in this kind of occasion.
And the EDP was 24 when it was done in the other hospital. Certainly MR, when it reaches the stage of LV decompensation, can lead to an elevated EDP, but of course aortic regurg can explain that as well.
Thank you, Dr. Nagar.
So I would summary that transthoracic TTE leaves questions to be answered that should be answered from the transthoracic before going to another step.
Okay, what test would you guys want to see next, or what do we think? We kind of have multivalvular heart disease, probably significant, definitely significant MR and maybe AI.
I mean, here's kind of the way that I approach it. If my question is really about the mechanism of the valve, I think then TE is a good next step. If my question is still trying to assess severity of the valve lesions, then I think CMR is probably the best next step.
I think in this case, you may need both, though, because if there is a question of MR, I mean, the question is, is this, is a 77-year-old gentleman, again, I think we are running short of time, but from a management standpoint, the options are going to be double valve surgery versus treat the aortic valve and see what happens to the mitral valve. If it gets better, then you manage medically. If it doesn't get better, then are you going to be able to clip this or not? So in my mind, I think I would like a TEE, and you may also, plus minus MRI. Dipan is on the panel, so MRI is always the right answer.
So MRI is next, but only because it was a research patient. The TE would have been done first.
And it depends if the patient is surgical versus high risk for surgery. So I think anytime you're considering a transcatheter intervention, you get a TE, you look at the mechanism, the feasibility for a transcatheter intervention, and assess the severity. You can answer all your questions. If they're surgical, then you can spare the patient an invasive test. And
Well, it depends transcatheter intervention for which lesion. So if you're doing planning a transcatheter intervention for an aortic valve, and we'll let Dr. Goel talk about that as he's the PI for the studies we're doing. Knowing a lot about the MR immediately is not so important because with a successful aortic valve replacement, you'll have decreased LV volumes, the MR may or may not get better, so you're going to want to wait before you make that decision anyway.
Yeah, especially if it's pure functional.
Whereas with surgery, obviously you don't want to operate on the guy twice in a short period of time.
this looks like a primary MR, so that's if it's functional, obviously, if the AR is significant and you fix it, you should hopefully expect some improvement in the MR.
All right. So we went ahead and did an MRI. So before showing the volume, so this patient is 68 inches, BSA is 195, 180 pounds. So we can see, again, CineStack images of a short axis base to apex. We can see both dilated LV and RV, some pericardial effusion. In the case of the LV, end diastolic volume 383 and RV end diastolic volume 372. When we index these values to the BSA, it ended up being severe biventricular dilation.
So one thing I'll just comment there, when you start to get LV diastolic volumes that are close to 400, mitral regurg almost never gives you an LV that big, right? It's almost always aortic regurg, at least a significant component, that's giving you a ventricle that gets to be that size. So that should be a clue right there, that maybe the aortic regurg may be more significant than what we thought initially.
Yeah, years ago, Bill Roberts used to call these the king of hearts because of the volume.
All right. So here we see a three-chamber view. In the MRI, we can clearly see a central jet of aortic regurgitation, and I have a short axis CineStacks of the aortic valve, and we can clearly see that there is a coaptation gap in the annular plane. So again, as I mentioned before, when we are trying to assess the severity of AR, we can use direct and indirect methods. Again, in this case, the direct method ended up being a 55% regurgitation fraction with a volume of 70. Again, we just did the math of the fraction 70 out of 127 forward flow. And we can also do the indirect method where we basically, with phase contrast, as I explained before, we assess the LVOT forward flow, and then we subtract the pulmonic net forward flow, and that should give you the indirect aortic regurgitation volume, assuming that there is no significant, pulmonic regurgitation that can confound the numbers. We can also, do the indirect method, subtracting the volumes, assuming there is no significant MR. So in this case, the indirect method and the direct method gave similar numbers with a volume of 78 ml with a fraction of 61, confirming that this is a case of severe AR. Again, as a confirmatory method, we assess by phase contrast, the flow in the descending aorta. And again, the curve below the baseline represents forward flow, and we have a holodiastolic flow reversal telling us that this is a severe case of AR. And again, with high-resolution CNE images, we can measure the anatomical regurgitant orifice, and in this case, it was 0.3 centimeters square. There have been some studies suggesting that more than 0.28 in CMR has a 90% sensitivity and specificity for 3+ AR. So I just want to stop here and see if the panel has any comments before showing the MR severity assessment.
Why don't you go ahead and show the MR as well?
Okay, perfect. So in the MR again, I want to draw your attention to the mitral valve in this 3-chamber view, and we see that the jet flow is severely eccentric, and that raises suspicion that this may be a case of a flail leaflet. We don't see a lot of prolapse in the 3-chamber, so you question why is this jet so eccentric. Raises a suspicion of a flail leaflet. And then I have a high-resolution, mitral valve here, and we can see in systole there is a coaptation gap in the middle. And then assessing the, MR severity, we need to first assess the stroke volume. So the stroke volume we computed, subtracting the end-diastolic volume and the end-diastolic volume. In this case, it was 192 ml. And then using the technique of phase contrast, we assessed the forward flow. And in this case, it was 127. So whatever is not going forward, it's going, to the left atrium. So we ended up in this case with 65 ml of mitral regurgitation. So in this case, in summer, we have a multi-valvular disease. A patient with severe biventricular failure, LVEF of 50%, the RV is severely dysfunctional, and we have both severe AR and severe MR, 70 ml and 55% in the aortic valve, and then 65 ml and 53% in the mitral valve.
Okay, so you've got a patient now who's got severe mitral and aortic regurg. He's 70-something, multiple comorbidities. What do you guys want to do?
Yeah, if we see this patient in the valve clinic, obviously we see these patients with our surgeons. First question is, what is the surgical risk? In general, for a double valve operation, the surgical risk, is not trivial. The predicted mortality when you look at the STS and other databases is upwards of, 6-7%, 8% mortality. So certainly, a transcatheter option, if feasible, will be discussed and entertained. And, in the order of things, we would treat the aortic valve first and then reevaluate the mitral valve. It may be helpful to know, whether this mitral valve is clippable up front before, we go down the transcatheter route. But certainly, I think, transcatheter aortic valve with a dedicated valve for AR, such as Jena valve or J valve, would be the next step for the evaluation of TAVR. So CT, I would do a CT next to do the annular measurements and see if the patient fits one of the dedicated TAVR valves for AR. Doing TAVR with a valve for AS has been shown to be higher risk situation with higher risk of valve embolization, valve migration, higher risk of mortality. This has been shown in various studies, including a meta-analysis from our group earlier this year. So a dedicated valve, if feasible, would be the ideal choice.
Yeah, so really first thing you want to see on the CT is how calcified is the aortic annulus. If there's enough calcium there, then you'd consider using a standard valve. And if not, then you'd have to apply for compassionate use for a dedicated aortic regurg valve, since with mitral regurg, he's not going to fit into the clinical trials.
Right. Yep. So TE was done just to confirm the mechanism to guide intervention as well. A CT TAVR will be done as well. So here we do see the A2 prolapse, and on the top left image, mid-esophageal kind of 4-chamber view, 5-chamber view, and our 3D reconstructions show that there is anterior prolapse, A2, lateral A2 with a flail segment at lateral A2. and that the MR jet on the right is this large eccentric sweeping broad jet wrapping around the atria. All right, so we already did a lot of volume quantification, but again, this confirms by PISA that this was an eccentric jet, but we were able to get a decent hemisphere and kind of give similar values for the regurgitation volume of the mitral valve. And again, pulmonary vein flows. The bottom, in the center bottom, we have some systolic reversal, and then in the bottom right, there's just blunting. But we know the severity. This was just to decide on the mechanism and see if it was if we were able to have it clipped. And no contraindications for MTR based off of this TE. So this was back in 2019, 2020. So at the decision, so that was the MR. Let's look at the mechanism for the AI first. So it looks like it's just this central regurgitant jet that is taking up a big area. So that the right coronary cusp is somewhat restrictive, creating that central jet. But tricuspid valve, a little bit of calcium, but not a normal calcified sclerotic valve, or that would not a heavily calcified sclerotic valve. It's just this focal maybe calcification causing this restrictive cusp. All right. The theme being eccentric jets. When we don't quite see how severe the jet is, go transgastric, and it's going to reveal itself. And if this jet was seen on TTE at the way beginning, it would have been, oh, this is severe AI, and it would have been missed. But given where the jet's coming from and the limitations of transthoracic, we're not always able to see that.
So neither lesion is dominant, and neither will improve by repair or replacement of the other. I think in this case, which it's kind of the we've always talked about, repair the dominant V lesion or approach the dominant lesion. They're both dominant.
Okay, so again, we'll talk about the intervention. What's the dominant lesion? Hard to say. If this was functional MR, fix the AI first, see if the MR gets better. Given the timing of this case being in 2019, 2020, they went ahead and thought that the AI lesion was the most dominant. A compassionate use with the J valve was used. And the J valve is one of two options, J and Jena valve, that are transcatheter valves that for severe AI, when you don't have enough calcium to put in a normal Sapien or Evolut or Navitor or any other type of normal valve that sits on the calcium or holds onto the calcium. These two valves, this one being the J valve, uses these kind of graspers that go into the cusps, and then the skirt attaches to it and creates a new valve or displacing the old one. This is just highlighting the two ones. The Jena one, which we're now seeing more with the Align trial being done here. The J valve, this was 2019, so we used it compassionately, but I guess maybe Dr. Goel, you can speak more about this as to, we're seeing Jenas here as opposed to J's.
So Jena and J are two valves. They are not completely sort of, overlapping in terms of, sizing. So the Jena valve has sizes which only go up to about 90 millimeters annular perimeter. So if the perimeter is more than 90, then they cannot get Jena, at least as of now. So the J valve goes up to 100, 105. So the larger sized annuli are suitable for J valve. And what we've seen is a lot of the AR patients have large annulus. They have dilated aortas, dilated roots, and as a result, big annuli. So this is a nice complementary valve to the Jena valve. The Jena valve has more data. The Align AR was presented and published. Align AR was a study of about 180 or 200 patients, but since then, the continuing access has, progressed, and we've done more than 800 cases in the US, and the data looks very good. Mm-hmm. The J valve is closely following Hughes. There's good data from the EFS, and now, the company has been acquired by Edwards Life Sciences, who's putting a lot of resources, and, the pivotal trial is ongoing.
Okay.
We expect that the Jena valve for high-risk patients is going to get approved in the next 6 to 12 months.
Mm-hmm. And then the Jena you can recapture, the J valve you can't recapture, correct?
So you can't, you can to a degree. There is a stage beyond which, you cannot.
Okay.
Yes.
All Any comments before we go to the post? We'll just keep moving. So this is the post, again, of valve.
Miguel?
Yeah, 77-year-old with comorbidities, double valve. If there's a transcatheter way, we'd probably try and push for that.
Yeah.
If he wasn't, you would just replace both, or would you try for the mitral valve? Is it,
Mitral valve, I'd still try and repair it if it's just A2 prolapse.
And of course, surgery was involved, CT was done, and all of this was deemed the most likely best course to take, surgical risk being in the high-risk category. All right, so our aortic valve is now fixed or implanted with a new valve. There's some mild trace, mild central AI, no PVL, and our MR lesion is still there. Normal gradients, DVI of 0.7 is a win. And then, so this patient was discharged, he was feeling better. At the time, it was like, okay, fix the AV valve and then see how he does. And he did good at first, for the first 3 months, then started having recurrent hospitalizations. And it's pretty obvious what the cause is, being that severe MR lesion. So he made it, almost a year though, prior to then discussing intervening on the mitral valve. So he was diuresed and then went for TEE. Sorry about this image, but we can't. Oh, there it is. We already have the TE images. They haven't really changed. This is the TE on that day. Again, showing that there is A2, lateral A2 prolapse and flail. And here we see both pulmonary veins having flow reversal. Okay, let's give that a second. Okay, so this is post-clip now. And really, really good results. Almost trace MR, just required one XTR at the time, I believe, almost down the center, a little bit lateral, creating a double orifice mitral valve. And again, the bottom left is the 2D, just showing that trace regurgitant lesion. The middle bottom is the pulmonary vein, looking a lot happier with the systolic dominant flow. And then our mean gradient post one clip being 4. So really nothing to chase after. Okay.
Right.
Any comments?
Okay. No, I think first off, I think we're kind of short on time, so I want to thank you guys for these presentations. I think this kind of nicely highlighted the spectrum with aortic regurgitation, where the first case is a young patient in their 40s and 50s with a bicuspid valve versus the other phenotype of patients, which are the elderly patients with degenerative trileaflet valves, where really the approach that you take may be very different between these two groups of patients. Yep. So in the interest of time, are there any other last-minute questions from the audience or comments from the panelists?
I think, Dipan, you summarized it well.
Yep. Good. And Dario and Andres, thank you guys. Outstanding presentations.
Thank you.
Thank you.
Guys.